So when the diagnosis of CLL is suspected, the simplest, quickest, easiest test to do is to run some flow cytometry on the peripheral blood. And the diagnosis of CLL can be made on peripheral blood flow cytometry alone. If a patient has very typical CLL, a bone marrow truly is not necessary to make this diagnosis. If there's something strange and it doesn't fit the picture perfectly, then absolutely patients do need a bone marrow aspirate and biopsy to gather more information. But if the flow really looks like typical CLL, there is no reason to put someone through a bone marrow. Now, of course, if the patient's going on a clinical trial or you have clinical trial options for patients, those typically will want bone marrows done, but it's something that we've really moved away from in the management of CLL. And in addition to the flow cytometry, it's important to get your prognostic indicators, to order your CLL FISH panels, to look at those prognostic indicators, to get your IGVH mutational status, to figure out if they have mutated or unmutated diseases. And those are some of the things that there are more pieces to the puzzle that you put together to figure out prognosis for patients. There are lots of other things you can draw, like CD38s and ZAP70s and beta-2 microglobulins, but truly the FISH and the flow cytometry and the mutational status are the most critical elements of that initial workup.